Good evening, ladies and gentlemen. I am Amar Lal, hematologist, oncologist in Tamam Hospital. And thank you for inviting me in Omani Society of Hematology conference. My topic is elevated the management, newly diagnosed transplant ineligible multiple myeloma patient. So in next 20 minutes in same contents, I will go through 5 steps. I will use the resources of NCCN and other guidelines to solve those challenges. My focus is 2 studies exploring the potential of the daratumumab and our real-world experience and advantage of DARA-based chemotherapy. My final question is, how do you predict DARA-based chemotherapy? So when questions arise, how to treat, how do you choose frontline management for multiple myeloma, which guideline you use? Everybody use first these 4 guidelines, and NCCN is top of it. And sometimes we use expert online. So let's go answer of these questions of NCCN guideline, what they say my frontline therapy for transplant ineligible patient in 2023. So we have now 2 options, DARA, Lendex, or RVD, both are in category 1. Then if I go for EHA, ESMO, for transplant ineligible patient, first option is again DARA-based chemotherapy, DARA-RD, DARA-VMP, and VRD-based chemotherapy. And if you go again, International Myeloma Foundation, what they say, they also emphasize DARA-based plus minus RD. And if you go by expert online, 80% say is DARA Lendex-based chemotherapy, and 20% is less. So these are the resources. But still, there are some questions people ask. If in a patient with a newly diagnosed myeloma, should we use our best treatment first or save them for later? Is it better to use VRD1 at first and we keep DARA for the future? Here is some analytical thought that we know multiple myeloma gets harder to treat with each relapse. Here you can see the remission will go after remission, relapse come very quickly if you don't use the properly because of clonal evaluation. So as somebody has said, that multiple myeloma is marathon, so you have to use long-term strategy to get a proper PFS. You have to use as a first line very carefully to treat the patient. So why everybody was saying all the guidelines you have seen that DARA-based is the first line based on which trial? Actually, 2 important trials, the Esaclone trial and Mayer trials, which are based on, you can say, more than about now total, if you can see 1,500 patients. And then again, there is real world experience data, which is more than 3,000 patients. So now tons of the patients we have available based on the trial, they have shown, we will see shortly, what is the PFS and what is the CR and what is the deep remission. If you go by these 2 trials, especially, and here you can see DARA-RD has shown higher the PFS and overall survival and overall response as compared to RD. And similarly, VMP versus DMP, DVMP has shown higher the overall survival and PFS and response rate. Without question, it's better. But if we go by detail, Mayer trial, which was recently presented in Update Always, EHA 2021 and 22, that this is about more than 700 patient randomized trial. Clinically eligibility criteria is who are not ineligible for transplant. And the primary endpoint was PFS, and secondary endpoint, of course, CR, MRD, PFS2, overall survival. So again, as randomized trial, they both are equally distributed in both arms. And what they have shown, the PFS over the 5 years, there is 47% reduction in the risk of disease, of the progression or death. So they have shown with the 5 years, 52% in PFS rate in DARA-RD versus 28% in the RD arm. Here you can go, it's very high difference. It not only PFS, it's translates into the overall survival that has shown 32% reduction in risk of death. in the DRD as compared to the RD. And this was seen with all type of the group, from the gender, age, and from all the baseline characteristics and the disease risk analysis. They have shown the higher in the DRD arm. It continuously persists. And PFS benefit even seen, especially the main focus is elderly patients, 75 years of the age. This is very interesting, which was not shown in other studies. They have persistently shows, here you can say median PFS even not reached for patients who are aged in the 75 years. And of course, there is deep response, which intends to treatment the population. They consist with the DARA-RD therapy. They have deeper response, and you can see subgroup analysis shows significant higher overall response, CR response, and all the response was seen in the DARA-RD arm. Here you can see all the greens. This is all the DRD. The deeper color is showing the deeper the response. Similarly, depth of response that was shown 3 times higher with the MRD negative as compared to the RD arm. Here you can see the big difference, 10% versus 31%, which was seen higher the depth of response. And response at 6 and 12 months, here you can see this is 6 months, this is 12 months. They have persistently MRD negativity shown higher in either 6 months or 12 months in the DRD arm as compared to the RD arm. So this is also showing the long-term time to progress or the death, which was shown excellent in the DARA-based regimen, DRD versus the RD in both in, here you can say MRD negative, and this is in MRD positive. Even positivity of MRD, they have shown the higher response, DARA-based chemotherapy versus RD arm. This also shows the prolonged PFS subsequent of the therapy, 35% reduction of risk of the progress or death and subsequent line of therapy was shown in the DARA-RD-based regimen. And time to subsequent therapy longer, median time to next to therapy was seen versus you can see here, still not reached in the DARA base as compared to the RD arm, and more patient on the RD received subsequent line of therapy, which was not shown in the DARA-based chemotherapy. And without any safety signal, DARA base has manageable safety profile, and DARA RD base a minimal additional toxicity was shown. So without any new safety signals was shown. These were the common side effects, some cytopenia and some electrolyte problem. Otherwise, you can say the chance of infusion-related reaction occurs is 0.3% in grade 4 and 2% in grade 3. So it is quite manageable. Not only this, you can say improvement of the quality of life, you can say is higher in DRD as compared to the RD arm. Now, not only this, if you go subsequent, the treatment duration and long-term outcome of DARA-based transplant ineligible patient, there is one trial which was published recently in August in the annual meeting. What they have shown here, the primary analysis of MEA trial was shown in 28-month treatment with the DARA-RD until disease progress, and versus RD in transplant ineligible patient. With longer follow-up now, more than 5 years, they have shown significant overall response and depth of response. How you can see here, the patients who are discontinued treatment, the treatment in the both arm, what is the result here? You can see over the 18 months, the patient with a median follow-up of 56 months and overall benefit of the survival was seen observed in DARA-based regimen who received treatment more than 18 months, who less than 18 months. So this also indicating that continuity of the treatment is very important. You can see here is a huge difference who continued the treatment rather than to stop the therapy. It was similarly translating in all the PFS and overall survival. Here you can see 18 months versus less than 18 months, and it was seen higher in the DRD arm. So similarly, deeper response was shown in the DARA-based regimen. So what they conclude in this one, that median follow-up of 4.5 years, DARA-RD improves, of course, PFS and overall survival versus only RD who received more than 18 months. For DARA-RD patient, discontinuation did not appear compromise the efficacy. No new safety signals were found. So these results support that DARA-RD for more than 18 months to achieve deeper clinical response. And our finding also suggests that stopping DARA-RD earlier based on the response level may compromise the long-term outcome. So this study also indicating the continuity of the therapy should be given in those patients. Now, in next 8 minutes, what I do, I have shown that all guidelines is favoring, and there are clinical trial more than now 5,000 patients. They have shown in different study, MAIA study, ESA-Clone study, and real world practice. They have shown higher the benefit. Let's see what we do. This is our analytical thought. I always choose by this way, by 5 lines of therapy, depending on the patient profile from green, blue, red, and orange line and thin line, depending on the patient risk strategy. I divided patient and treat the patient accordingly. And then I use the A to G of the to treat the multiple myeloma, A for accurate diagnosis, then B for beginning the treatment, check indication, then check the cytogenetics. Let's see how I do in my patients. So this was recently patient in 2022, 78-year male, who had history of backache and who has 2 comorbidity, diabetes and hypertension. And he went to some clinic, finally found a lytic lesion. He was referred to us. And here what we did, you can say the beta-2 microglobin and LDH was high, albumin is low, and the pathology confirmed also multiple myeloma with a FISH hyperdiploid. So A means accurate diagnosis. We have IgG kappa multiple myeloma, ISS stage 3. Standard risks now before beginning treatment, check indication. Yes, there is indication of the treatment. C, check the transplant eligibility. Naturally, this patient is not eligible for transplant. Now, what is the best treatment option for this patient? We know evaluation of the treatment has gone, MP versus Lendex, then RVT. Now we are DARA Lendex. So this is how NCCN put it. Either you can do from these triplet, or you can go for IRD, or you can go for DARA-based chemotherapy. Now, as I mentioned, I use resources. If you go by resources, NCCN, they put DARA-RD as a first category 1 preferred regimen. International Myeloma Group, same. And similarly, EA also says DARA-RD. Expert online, 80% say DARA-RD-based chemotherapy. So what we did in this patient, actually, we choose also DARA-RD-based chemotherapy, which is MAIA-based trial. You can say after first cycle, the patient become pain-free, and subsequently, after 4th cycle, he is very good partial response, and the patient is continue on the DARA-RD-based chemotherapy. This is case 1, which I call as a blue. Second case, I would say blue and red line. This patient is 70-year lady who has actually very poor performance because of multiple comorbidity, and especially she presented very badly, acute kidney injury, hypercalcemia, cancer-related pain, and patient had related all the troubles there. So we started initially, calcitonin, denosumab, and all these things, and finally, to start the DARA Lendex chemotherapy. And this was he has pathological fracture in actually humerus and radius, 2 fractures were there. So we started DARA-RD-based chemotherapy. Here you can appreciate just after 1 cycle, she has responded from 70 to 35. It's a huge response. Of course, clinically, she is fine now. She is now 3rd line, 3rd cycle of the chemotherapy, and she is doing great. So similarly, this I call as an orange line. This is middle-aged male who was not eligible for transplant. This patient initially, you say he took VRD-based chemotherapy, but you can see it was high-risk patient and the patient disease progressed. And finally, we came to DARA-KD-based chemotherapy. This is, I just wanted to show you, if you don't give properly DARA in the beginning, eventually you give very subsequently, very quickly. As it was shown with the RD only, the patient has more fractures. So 4th is actually, I would say, red line. And here again, I would emphasize this patient has extramedullary and plasma cell leukemia, middle-aged male. And the patient, from the beginning, VRD, then, KD-based chemotherapy. And finally, the patient has on DARA-KD-based chemotherapy. Now, over the 3 years, you can see the beauty of the novel agents, the plasma cell leukemia with extramedullary and renal insufficiency patient, he is doing great in the red line. Now, for 5th is the green line. The patient over the 1.5 year, the patient is not eligible for any chemotherapy, and patient family also declined for any to take any chemotherapy who has caused any side effect. So finally, we discussed with her, and about the 15 month, she just simply monotherapy of Dara-based regimen, and she's doing great. And you can see the curve of this one. So this is the green line. So what I try to emphasize in real world practice, as I showed, green line, I show you, you can choose even simply regimen, it will work. And red line I showed in plasma cell leukemia, it worked very nicely. Blue line and orange line, both I showed, I started from the beginning, and it works also very nicely in my patient as well. So in last 15 to 20 minutes in contents time, I talk elevating management of newly diagnosed transplant ineligible patient. I go through the first challenge, whether should we use Dara as a first line or not. And in the light of two studies, especially the MEA and the Alcyone trial, they have shown huge difference, which I showed in the curves as well. They have, and after this, there is 3,000 patients, the real world practice. There is data there. So this also replicate in all guidelines, as I mentioned, NCCN, Expert Online, EA guideline, and International Myeloma Foundation. They have all put Dara as a first line. So now currently I have shown a couple of patients in our practice since 6 months, we are using Dara RD in non-transplant eligible and Dara RVG in transplant eligible practice. And we have shown also the advantage. And of course, this is based on the trial and all the guidelines we are using now. My question is with you, how do you predict for the Dara-based therapy in 2022? Thank you very much. I am here to answer you any questions.